Thank you, Mr. Chairman. A number of the witnesses have discussed the age banding, and we know that there are approximately 8 million people that have chosen to not buy coverage either because they can't afford it, they don't know enough about it, or they've just simply decided it's a better deal for them to pay the penalty. I'm wondering if, I know Ms. Turner and Dr. Blumberg have both referenced in their testimony the 3-to-1 ratio, which is in statute as I understand it. What should, if the panel could each offer us, what should that ratio be if we are to amend that portion of the law?
This would be a decision best left up to the states, but a 5-to-1 age band was previously considered a pretty good standard, but it's something that is very difficult for the federal government to make one standard.
From my perspective, you shouldn't change the 3-to-1 age band to something broader unless we provide more financial protection for older adults, because the point of putting those tighter age bands in was to make it so coverage was not excessively unaffordable for older adults paying for their full premium. So if you can put in more consumer protections, financial protections, for example, everyone over 400% of poverty pays only no more than 8.5% of their income for a standard policy. Then you can loosen to 5-to-1, because what you're doing is you're redistributing these very high costs that we accrue as we get older by income instead of by age. But for now, I wouldn't move that.
Thank you.
But the effect has been to discourage young people getting in, and actually it harms older people now currently because the younger people simply don't enroll because of this 3-to-1 band.
It doesn't harm older people, and I think you've far overstated the circumstances. It's my turn now. You've far overstated the circumstances because age is very inversely correlated with income. So actually a very large percentage of our young adults are eligible for financial assistance, which caps what they have to pay relative to their income when they enroll through the marketplaces, and that protects them. Our analysis has found is that there is no difference in coverage as a consequence of 3-to-1 versus 5-to-1. It's a matter of who's going to be uninsured, a little more uninsured, older adults who need a lot more care or younger adults who need less.
Thank you, Dr. Blumberg. Dr. Book, did you have something to add to that?
Yeah, thank you. To answer your first question, I'd recommend not specifying that in that ratio in the statute. Prior to the ACA, some states did not have that in their own state statutes either, and the ratio is usually 5-to-1. We find with the ACA, premiums even for older Americans have increased relative to what they were before. So I don't think this 3-to-1 is necessarily saving them money because they're paying more. Okay,
Mr. Haselmeyer, do you have something to add to that?
I can supply you with a study that was done by the American Academy of Actuaries that has looked at the relationship between age and healthcare expenditures. And basically, when you look at that, if you assume that there is a blended rate, meaning that you're not differentiating between men and women, because women tend to be more expensive younger, and then that flips and men are more expensive when they're older. But if you assume a blended rate, then the approximately 5 to 6 to 1 range is the natural variation in healthcare spending, and
Thank
that
you.
would be.
One last question that the panel, if you could briefly answer, since I have 1 minute and 19 seconds. The essential benefits, my understanding that is done through strictly regulation now at HHS. What changes would you recommend in that regard, Ms. Turner?
There are 10 specified categories in the ACA. The HHS Secretary has broad license to redefine those, and I think that is something that the American people would like to have looked at again so that they can have more flexibility.
Dr. Book?
Yeah, I'd like to say a word about preventive care, which is listed as a general category, but somehow in reality, preventive care does not include anything that actually prevents you from getting sick. For example, high blood pressure medicine is not included, cholesterol medicine is not included, blood thinners for people who have had strokes is not included. It just includes things like vaccines, screening tests, and contraception. So a lot of the things that actually prevent people from getting sick and prevent people from needing more expensive treatments are actually not counted as preventive care according to the ACA and its regulations.
Dr. Blumberg?
One must remember before you remove something from an essential health benefit or remove all essential health benefit requirements is that as soon as you take something out of that benefit package, it is out of the sharing of healthcare risk across the population. And any individual who needs that particular type of care is going to have to pay for it completely out of their own funds. And this will make that unaffordable care in many circumstances for many individuals.
The gentleman's time's
Thank you, Ms.
expired.